Hello, so good afternoon friends. I am Dr. Viveka Kumar, Senior Director, Cardiology Department, Max Healthcare. So today I am going to discuss about the non-surgical aortic valve replacement technology, which is called TAVI or TAVR. As you would know, as the aging population is resulting into degenerative severe aortic stenosis, and almost 5% of the population beyond the age of 75 are getting affected by that. And as the age advances, they become high risk surgical candidate and they cannot get the surgical correction or what we call SAVR or surgical aortic valve replacement, simply because they get multiple comorbidity, and as age advances their surgical risk goes high. So 30% of them, they don't really get an opportunity to get the valve changed, and their longevity decreases. So TAVI is a procedure whereby, like an stent, we go from the artery, either femoral artery or axillary artery, and remove the valve and change it by what we call stent mounted valve, which is called TAVR procedure. So in this, like if you can see this heart model, this is the aortic valve, and if you look at the stent, this bright part is the stented part in which there is a tissue valve attached. So this goes through the right femoral artery, and we take it across under local anesthesia across the diseased aortic valve, place it accurately under fluoroscopic guidance. We also take simultaneously echocardiographic guidance, and then we implant it. So it is a self-expanding valve, and the other variety is balloon expandable valve. So both are available, and depending on various indications, we either put the self-expanding valve or the balloon expanding valve. And since it's a tissue valve, the patient does not need oral anticoagulant, they just need an oral antiplatelet, which is like an aspirin and clopidogrel. And the advantage is that the risk of sudden valve occlusion is not there. The patients, the longevity of these valve has been now proven, long-term safety data is there, and more importantly, as against the mortality of these patients during the procedure compared to the surgical valve implantation, it's significantly lower, almost 4-5 times lower than the surgical valve implantation in these high risk group. Initially, this procedure was reserved for only patients who had high surgical risk, but now after the TAVI trial, we have seen that even in patients who are intermediate risk, it is good because the mortality and morbidity is lesser, and we are undergoing studies in low risk group where in younger patient whether we can give that or not. Another beauty of this procedure is we call it valve in valve technology, where if the patient had previously surgically put aortic valve, and if that valve has failed, we can put another valve of this kind through that valve. So this is called TAVI valve in valve procedure, where such a serious disease where the valve has failed, if we do a redo valve replacement surgery, the surgical risk is very high, the patient's mortality is also very high. But if we go by this technique, the surgical risk, the procedure risk is very low. The patient can get mobilized next day and can be discharged also within 48 hours. So that's the beauty of this procedure. So failed valve, the valve either in the aortic position or in mitral position, we can do this procedure and the patient. So this is a boon in the medical technology in these patients who had no hope or had a hope at a very high risk can avail this treatment. So we are doing this procedure regularly. There are very few centers in the country which have been recognized for this, and we are one of them. And both the technologies on the TAVI procedure, whether it is balloon expandable valve or the self expandable valve, is equally good. There are certain patients where the one technology is better than the other. If the aortic annulus is very small, we prefer to put the self expanding valve, and those patients who have had valve in valve, there also we can put the self expanding valve, and these patients have been shown to have very low risk during the procedure. And one of the concerns which was initially that whether these valves would last long or not has been allayed, because the data has suggested that these valve has got longevity as good as surgically put tissue valve. Another advantage is that these valves, as they do not have any ring across, so the effective valve area which is achieved, or what we call post implant aortic valve gradient, is significantly lower than the one which is put in the surgical valve. So that is again a major advantage of this procedure. And the big advantage is that the patient does not have to take the oral anticoagulants, just the antiplatelets are good enough. And those patients who have got other comorbid conditions where the general anesthesia cannot be given, the lungs are very bad, if the patient has got a renal failure, so in those situations also this is a better technology to go about than going for the conventional surgical technology. As far as the risk of infection and other things are concerned, that is also lesser because the procedure is less extensive. The immunity of the patient is not compromised because the patient is not on had big scars, and also in this situation the risk of infection is also lesser. And the valve sometimes can, what we call valve migration, it is also very easily treatable, because if the valve is not in position, we can always retrieve the valve. So newer technology is that once we have deployed this valve and not disconnected, then if the parameters are not to our satisfaction, we can sheath inside the sheath and then redeploy the same valve. We can do it 5 times in the same setting, and after that we can take another valve and deploy it there. So the technology is moving in such a direction that this procedure is getting more and more safe. One of the concerns or side effects was what we call paravalvular leak, where the leakage from the side of the valve used to happen. But with the newer valves, the what we call Evolute R and Evolute Pro valve, and even the Sapien 3 valve, the skirt of the valve has been strengthened so that the leakage, paravalvular leak, is significantly lower. The other problem was that almost 30% of the patients used to need permanent pacemaker because of the damage to the conduction tissue by the lower end of the valve. Now we have been putting valves slightly higher and the valve technology has improved. So the risk of these patients going into the complete heart block and needing the pacemaker has also gone down to less than 10%. So that's again a very good news that the patients and that need is as good as patients who undergo surgical valve replacement, similar rate of pacemaker implantation. To conclude, I would say that this new technology of percutaneous valve implantation, or TAVI or TAVR, is a revolution in the field of cardiac medicine and has changed the life of many patients. Initially it started for high risk older patients, but now it is for even low risk groups. So middle aged patients can also avail this, and those patients who have comorbid conditions, they can also avail it. So this is really a boon in the field of cardiology. Thank you very much for your kind attention.